Starting with the potential pit stops that you might have during the procedure by using imaging. A lot. You can do imaging before, get lesion characteristics, stent size, length. You can go with imaging across all the different steps. But the point is, what is really important and in which type of bifurcation we should approach with imaging. Here you have a couple of risky situations. Patient presenting with unstable angina and what they call complex artery through bifurcation 111 or 011 Medina, and you have in a 2-to-1 propensity score match in hundreds of patients, and this is the results of using imaging at 1 year. The strategy was changed in about 1/3 of the patients. The adequacy of the expansion was reached in more than 80% with a significant impact in terms of MACE. What about long term? 7 years later, the same group of patients, you can see the big difference in what? Marginal aspect? No. Total cardiac death and revascularization. So when you are moving to the high level of complexity, there is some difference. Not all the bifurcations are the same. Data coming from Renovate complex PCI. So the first randomized study in a 2-to-1 showing the impact on imaging versus angio guidance. And you can see the subgroups. Unprotected left main coronary artery disease, very good result. What about global through bifurcation? Neutral. So it's important to understand that depending upon the level of complexity, we might be in trouble clinically. There are data from the Excel comparing what we can achieve in the left main when we are comparing to surgery based upon the ostial and the body of the left main, where we can compete very nicely compared to the distal bifurcation. So two concepts. So when you have a challenge in bifurcation, you are challenged by the adverse events. And the second one is try to keep simple. This is the case. 15 years old, coming with unstable angina. And the question becomes, should procedural planning be part of a standardized set of imaging guidance criteria? And my answer is only one, yes. Yes, but you must use high quality of imaging, likewise we have today, it doesn't matter which technology, and full information. And full information means also longitudinal extension, means where to land, means the type of plaque, taking measurements, why we need to watch around, for instance, at the landing zone. There are results from the ultimate trial, with about 1/4 of the patients with a bifurcation, and 10% with a left main PCI. The most frequently failed IVUS criteria was plaque burden more than 50% at the edges. So don't be concentrated only on the plaque, but watching around. And that is becoming very important when you are dealing with a ostial lesion. Here you can see an example. Should procedural planning watch around, especially at the ostium of the LAD and the circ? Here you have when you try to nail the ostium and when you doing a crossover based upon the imaging extension in the left main. And you can see the difference in terms of TVR. There are data in support of this? Yes. Here you have the intracoronary imaging on proximal lesion when you compare imaging to the angio guidance. And if you are going to the bottom of the slide, you see that when you are using imaging in the ostial lesion, you might have a lower rate and a better survival, lower rate of TLR and a better survival, primarily due to which type of lesion, the ones they are referring to the left main. And so it's becoming the more and more relevant to watch around. Pit stop number 2, try to get measurements. Why try to get measurements? Because measurements are very important to decide the size of the stent based upon the distal reference, but also for fixing the size of the pot when you finish the procedure. Which type of measurements? The most simple. The length of the lesion, the landing zone, and the size that you might have for the pot. Can we do by using just a single imaging technique? No, you can do by using multiple imaging technique. But then you have to add also another p-stop that look to the plaque, to the distribution, eventually to the carina, and the risk of the side branch occlusion. And here you have an example of the possible contribution of the OCT. What about the type of plaque? How much can be impactful on outcome? Here you have some study focusing on the characteristic on the main vessel. And here you see the importance to have a look at to what? In the main vessel, to the amount of lipids that you have around the side branch. And when you are growing in terms of amount of arc of lipid and a volume lipids, you might have a maximum risk of a side branch occlusion. But of course, that was obtained by OCT. Here you have the same obtained by using IVUS, where it's not only the main vessel to watch. For the left main distal bifurcation, is also very important to have a look at the type of plaque. If you have a calcifying nodules at the origin of the circ, that could be one of the major aspects for getting in trouble. We will continue to always use the same images. This is from Dr. Lee. I don't think so. I think that images can be used in the future to get a better characterization and a prediction before going to the procedure in a growing number of patients coming with non-invasive information of the risk to get problems during the procedure. What about calcium? It's not only to see or not calcium, it's how much we can gain when we are treating calcium. Here you can see the same pair images in the patients when you have a huge amount of calcium after the shock wave without any significant result. Unfortunately, in this case, you take measurements and then you can see that you need some escalating of lesion preparation. That go into rotational atherectomy and what is possible in the two different branches. Very, very important. When you are coupling the imaging technology with the best of technique that we learn from the clinical data, in this case, you have the combination in a huge number of patients with unprotected left main distal bifurcation of imaging guidance, IVUS and OCT, and POT optimization based upon the clinical and the imaging criteria. And you may see the significant impact in terms of outcome. That is marginal, is not marginal. You can see that the most impactful were on stent thrombosis and sudden cardiac deaths and longer-term cardiac mortality. They are very important factor on this branch. Stent optimization criteria should be part of the imaging guidance. My answer is yes. You need to check the coverage, the apposition, the MSA, the expansion, and of course, the symmetry of the carina. When you are confronting with this session, you can see clearly the difference between what is optimal and what is suboptimal. There is a space for other variables. Here you can see one possible contribution that is in the link crossing and detection of the link crossing the major branches, especially at the level of the distal left main. How much is important? Here you can see the difference. When you compare all the bifurcation with the distal left main bifurcation, if you are leaving the link crossing the branch at the level of the left main, you have a much higher risk of restenosis. It's not applicable systematically to all branches. Do we have suggestion for using imaging in the best setting, and which one? Here is the document we produced in 2018, said they are the subgroups of patients that can benefit of imaging to be guided. And you see the left main, and you see in the best country in Europe, the percentage of the people approaching the left main by using imaging guidance. And here you can see on the left side, the potential impact in terms of mortality when you are using imaging versus angio guidance in the distal left main. Everybody is claiming that if we needed to use imaging, we would like to do in the left main and in the proximal LAD. But unfortunately, this is the reality. When we are confronting the use of imaging, you can see that also in this high-risk situation, there is a spectrum of use across all these hospitals and all the interventional cardiologists. One additional pit stop that we recommend when you are in doubts of something, please use imaging. There are trials, they are coming for IVUS and for OCT, randomizing patients to angio guidance versus imaging guidance, and they will be available soon. The conclusion are bifurcation PCI planning. The concept that the bifurcation are different is tenable, and the more complex they are, the more there is the need to get a planning by using imaging. High-resolution tomographic imaging, it doesn't matter if it's invasive or non-invasive, are seminal for ameliorating understanding and treatment. As we said, the randomized trials are coming. Bifurcation PCI optimization, we needed to redefine the optimal procedure benchmark at all steps. Thank you very much.
Thank you, Guru. I think you have made it very clear that very bifurcation stenting need imaging, and very good imaging is required for a successful procedure. Do you think that there is any situation where imaging may not be required?
Well, I think that the clinical judgment Antonio was alluding before is always important. So don't go in trouble because you wanted to do at any cost. If you are in doubt, doing in the main vessel can be more than enough to get some information about the bifurcation. But the extension of the bifurcation, the clinical relevance of the situation is very important to try to stay oriented.
Any questions, comments? Okay, if there are none, I think we'll give him a big hand.